So let's, in the interest of time, let's go ahead and get started. It is my privilege today to introduce to you Dr. Erik Geissal, who is the CMIO at OCHIN. And as you guys know, OCHIN is one of our valued partners for the Clinical Informatics Fellowship Program. And also, the experience, I think, that consistently has got the best reviews, responses from fellows who have participated in it. Erik is an internal medicine physician. He did his medical school from Tufts, and then his residency in internal medicine from Providence, Portland. So he is a native Portlander almost. And then he comes to OCHIN via Kaiser. So he's bringing a lot of really interesting experiences of East Coast medicine, West Coast medicine, community health centers, integrated delivery systems, and now trying to deliver healthcare to a population of clinicians who most desperately needs the pooled resources to provide them with the leverage to practice medicine in a way that many of us in academic medical center and large community healthcare systems have taken for granted. So I think the mission of OCHIN is a particularly interesting and a particularly noble one from an informatician's perspective. And the fact that they have, participated so closely in the Clinical Informatics Fellowship Program is to our benefit. And although there has been a rich tradition of OCHIN and OHSU collaborating on projects together, I think this is the jewel in the crown for both institutions for collaboration. And with that, I'll hand it over to Erik.
Thank you, Vishnu. Really appreciate that. I think that's the nicest introduction I've ever received. That was great. I wish I would have recorded you. Can you hear me okay? On the phone? Okay. So I want to thank everybody for being here in person and on the phone. It really is an honor to be here. Vishnu asked me to do grand rounds maybe 6 months or so ago. And, as with everybody else, public speaking is probably not everyone's favorite thing. It's not my favorite thing. So to say I was looking forward to it might be a little bit strong, but I was strongly anticipating this moment. And putting these slides together has actually been kind of fun. So I'm actually looking forward to telling all of you guys about OCHIN, teaching you about OCHIN, and sharing with you what we've been doing with the Informatics Fellowship Program at OHSU. As Vishnu said, I'm CMIO at OCHIN. I've been there for a little over a year, and I currently practice medicine on Fridays at Clackamas County Health Department, who is an OCHIN customer. So I use the EHR that we serve. And I also have this lovely adjunct position here at OHSU. I certainly don't want to turn down the heavily subsidized TriMet sticker or the Prox badge that lets me into the office so I can go to Monica's candy jar. Always very appreciated. One of these days I'm hoping that this disclaimer slide will actually I have to make it because I have so many investments that I have to somehow worry about it, but I don't need to worry about it right now. So this fellowship and OCHIN's collaboration was really meant to be. Back in 2016, only a year ago, I got an email from this guy named Vishnu, and it started out something like this. Hi, Erik, can we send you a fellow? And I said, sure, I just started. Who are you? And he said, I'm the Fellowship Program Director at OHSU. You may have heard of me. I'm kind of a big deal. I said, oh, Vishnu, right. Who is this guy? Oh, we're sending you an interventional radiologist first. He's really drunk the fire Kool-Aid. I said, oh, fire Kool-Aid? He said, fire. Are you really an informaticist? And as it turns out, though, as Vishnu and I started talking, we realized we actually share a common past. So some of you may know, I grew up, I spent some of my childhood in India. And Vishnu and I actually grew up in the same part of India during one of his travels around. And as we were chatting, I was thinking, it's funny, we grew up in the same part, and yet we didn't really know each other. I mean, I know he looks a lot older than me, but I think we're about the same age. And so I went looking in my photo library, try to find a picture of the two of us. And actually, Vishnu, this is my first time telling you, we actually did know each other in high school. And I found photographic proof. There's the two of us right there, hanging out. Okay, enough about that. So let's talk about what we're going to talk about today. So the first thing I want to mention is, what is OCHIN? Okay, a lot of people don't know what OCHIN is. They see it around, they kind of see the building on Nato Parkway, but they don't really know what we do. Okay? Then we're going to talk about informatics at OCHIN, which is actually undergoing, I would say, a renaissance, but that might be a little bit optimistic. I would say it is going through a rebirth. Okay, so this is actually a crucial time at OCHIN for informatics. We'll talk about this really productive, wonderful relationship that OHSU, DMICE, OCHIN are having together. And then we'll end with questions. Okay, pretty simple outline. What is OCHIN? I get this all the time. OCHIN, I see it on Care Everywhere. Oh, is that the Health Information Exchange? That must be it, right? What does it stand for? Okay, so today, this is how we often see it, right, in Care Everywhere. This is what I saw when I was at Kaiser, was I would look in Care Everywhere and I would see, oh, OCHIN. I have no idea what it was. I would click on it. There was some clinical notes, but I didn't know what it was. Okay, we're going to start with a quiz. And you notice, Vishnu, what's this?
Oh, I have a vague idea.
Yeah. So, in a nod to my brother from another mother for his World of Warcraft addiction, every time you see this symbol on this presentation, it is going to be indicating that this is the answer to one of the 5 CME questions is going to be on the slide. Okay? So this is, I'm giving you the biggest heads up ever that if you want to get your CME, you need to know the answer to these questions. Okay? So, what does OCHIN stand for? Who thinks it stands for Oregon Community Health Information Network? Hands, please. Okay. We got 2 in the room. All right. Orange County Healthiness Network? Probably not, huh? Outside Communities, Humanism, and Nature? No takers. Okay. OHSU's Community Health Independent Naturopaths? Nobody here? It doesn't stand for anything. Okay, the ayes have it. All right, so OCHIN used to stand for, number 1, Oregon Community Health Information Networks. Once we expanded outside of Oregon, it didn't really make any sense anymore. Okay, so we're kind of like IBM. It used to be International Business Machines, now it's just IBM. Now we're just OCHIN. Okay, I've seen it actually spelled like this before, which I actually kind of prefer to this all caps thing, but This is a stock slide. You'll notice the hideous background and the sort of, by the way, these slides were not cleared with my marketing department, so if you know anybody at OCHIN, please don't share these with them, okay? Because, and by the way, these didn't go through recipient QA either, so you have no idea what you're getting. But you notice this is sort of a generic, it's a nonprofit healthcare innovation center. What does that actually mean? Designed to provide knowledge solutions, yada, yada. All right, this is what I tell people, because it firms it up in their brain, especially clinicians, okay? We are a nonprofit healthcare IT company. Say it with me. We're a nonprofit healthcare IT company, okay? Focused on the nationwide safety net, based in Portland, okay? We have a building. It's actually a physical space on Nato Parkway, okay? It's a nice building. You guys, if you want to visit, by the way, just get in touch with me. I'll give you a tour. What we do is a number of things, okay? This is just a sample, but it's a core of our business. We host 2 different EHRs. There's a CME question on that, but there's an answer on a future slide. We run a nationwide medical grade network, so actual fiber cables to our member sites where we host them on EHRs. We provide data aggregation. We do reporting. We do visualization with that data. We do coding and billing services. One thing we'll get into is that our main customers are FQHCs, federally qualified health centers. The coding and billing especially is a little bit different for them, and sometimes these FQHCs don't have the funds to create their own specialized coding and billing staff, so we do it for them. We offer training. We do workflow engineering. We do quality improvement coaching for clinics that are looking to transform their business but don't really know where to start. And we do a lot of research. So we do research specifically on the safety net, and we'll get into that a little bit more. What don't we do? Oh, CME question, right? Got this symbol. Okay. We don't own or operate any of our own clinics or healthcare organizations. We are not a deliverer of care. This might change one day. We might decide that actually we need to put some skin in the game, learn some on-the-ground skills instead of telling people how to do things, but it's not something that's currently in our wheelhouse. Okay? So when people say, oh, OCHIN clinics, there's no such thing as an OCHIN clinic. There are clinics supported by OCHIN. There are OCHIN customers, but we don't own any clinics ourselves. Sometimes it makes it a little bit more real for those of us in Oregon to know who are our local customers. So you know who's on OCHIN. There's a lot more than this in Oregon and in Washington, but these are some of the big ones. So Clackamas County, where I work, Multnomah County, OHSU. Your Richmond and Scappoose clinics don't use OHSU's Epic. They use OCHIN's Epic. Okay? Outside in, Pacific University, Virginia Garcia, and then, of course, Wallace Medical Concern. When I was in residency, I volunteered at Wallace Medical Concern. It was all paper charts. It was great. You just scribble something and you're done. And, you know, now they've drunk that Kool-Aid. Okay. I'm going to go through this real quick because this is a lot of stuff. All right. So where did OCHIN start? 2000. It was founded. And initially what happened was there were some clinics that got together and said, you know, we really want to get a robust EHR. Epic said, yeah, you're really too small. Clinics all banded together and said, okay, how about now? We're bigger together. And Epic said, okay. And that was essentially the start in a nutshell, okay? And it developed after that. So the Practice-Based Research Network was created about 7 years after creation of OCHIN. We became Oregon's Meaningful Use Regional Extension Center. We integrated with the Social Security Administration. We deployed, this is actually, I want to get back to this a little bit later. We deployed to corrections, behavioral health, and naturopathic institutions. That last I'm very interested in particular. And let's see. You can see basically there's a lot of sort of, you know, milestones of how we went through and became the company that we did. This one in 2015, we introduced Acure, which is a data aggregation engine, visualization portal for clinics that are looking to take their medical data and report for meaningful use purposes or just for quality improvement purposes where they can see trends, they can drill down to the actual provider, drill down to the actual patient, full PHI, and you only see your own data, you can't see anybody else's data. And then we started acquiring a couple of companies most recently in the past year. So that at the end here, you know, we've been hosting Epic for a decade and a half. We acquired 2 companies that host NextGen. Okay, this is a CME question right here. Which 2 EHRs do we host? Epic and NextGen. Okay, and the reason we did that was to diversify our holdings in the EHR market. We didn't want to be entirely Epic dependent, and NextGen is the most popular FQHC EHR. It's inexpensive, it runs lightly, it works pretty well. We wanted to get into that market. So we acquired a company based in Washington State that hosted 5 practices. We still host them. We also acquired a NextGen company that actually builds the templates. If you know NextGen, you know what I mean when I say templates, for Planned Parenthood clinics in a variety of states. So we have that expertise now as well, which has actually been great because we can reach out to Planned Parenthood Federation of America and ask them questions directly that we never had a conduit to ask them before around women's health, around reproductive health, which has been actually a really great boon. And then finally, we want to get more into the telehealth space. And so we acquired California Telehealth Network that has a lot of California-based customers. They are a telehealth resource center. They have a lot of internal knowledge. We wanted to tap into that. So we purchased them. So now we have an office in Seattle for the NextGen clients. And we have an office in California, in Sacramento, in order to host the telehealth that we do. And then we're hoping to take that telehealth knowledge and expand it nationwide. Here are where our customers are. Now, I mentioned Acure, which is our data aggregation engine. You notice this is 126 organizations. That's more customers than we have on EHR. That's because we don't just have Acure customers who we host on EHR. Anybody who wants data aggregation and visualization and reporting can come to us. We don't have to be hosting them. We just need to set up the interfaces so we get their data. We do billing, obviously, as I mentioned. We do broadband connections, so about 3/4 of our hosted customers are on our broadband network. And that's outside of the internet. There's always a minimum speed, so they always have a fast connection. We host 106 organizations across about 18 states on Epic. We host, this is a little misleading. We host 5 organizations on NextGen. The other 30 are those Planned Parenthood clinics that I mentioned where we maintain their templates, but we don't actually host them out of our servers. We do a lot of research, as I mentioned. We're Oregon Medicaid's Meaningful Use Technical Assistance Program. So if an organization in Oregon says, we want to meet meaningful use requirements, and we're mostly Medicaid, they can come to us for advice, and we can help them coordinate their work. And then, of course, the California Telehealth Network, the 80 organizations in California. You can see that there are states that we don't cover. This map is also a little bit misleading in that if you look at patient volume, it's almost entirely concentrated on the West Coast and in the Boston area. We cover these territories, but the volume of patients is more concentrated on the West Coast where we started and in the Boston area. This slide is specifically about OCHIN's Epic business. You can see in terms of patient visits, we've been growing like hotcakes. Obamacare has been good to us, okay? Because more people get coverage, you can pay for your health care now, and we charge on a, the more patients you see, the more we get paid. If you can see more patients, we're going to benefit as well. So the more people get coverage, the better we do, right? It makes sense. This 5 time zone thing can be annoying sometimes because keep in mind we have a single Epic instance, one. So we don't have a different instance in different areas. We share this entire instance across 5 time zones and across the 18 states. And so it can make it difficult when there is a regulatory program that has different criteria in different states, right? There's this tool called CRAFT. I'm an internist. I don't really know much about it. All I know is that different states require it to be done in different ages. Massachusetts is 26. Oregon is 18. Indiana is 21. We want to find one tool that works across the board. Building that can be problematic, but we get around it. We fix it. This is another CME question. Which population do we serve? Okay. The safety net. Okay. So this is mostly government insurance or uninsured or underinsured. These are the people that we try to serve. You can see mostly it's female, a lot of chronic conditions. This is probably the most illustrative graph, I think. 24% uninsured, 48% Medicaid, 9% Medicare. Only a small smidgen on private insurance. Okay. I show this slide. I was actually thinking about taking this out. I mean, we do a lot of HIE, Care Everywhere Patient Records. I wish I had sort of a benchmark to show you to compare. But because we are a large organization spread out across a lot of different clinics, there's going to be a lot of HIE. I left it in just because we're proud of it. You know, if there's one thing we do really well, it's technology and HIE in particular. Our CTO is on the board of the Sequoia project. So he's had a large hand in directing the progress of care quality. And so this is something that is most definitely a strength. And interfaces are also a strength for us. Keep in mind that we need to interface with the labs that our partners all work with. So if a clinic has 3 different labs that they use Quest, they use LabCorp, they use some private company, we need to somehow create an interface with them. It comes into our Mirth interface engine, and we need to maintain every single one of those interfaces because each one of those discrete lab codes then drive the reporting on which the clinics depend for their financial health. Right? So this is a really important piece of what we do. So since our customers are all spread out, so do our employees have to be. Most of us are in Oregon, but certainly not all. We're spread across really all the time zones except for Alaska and Hawaii, obviously. We don't have any clinics in Hawaii. I think that's an oversight. We should probably do that so I can do site visits. You can see that most of our employees really are in the technical category. We are growing our professional services. I'm actually not sure why this is showing up this way. Looked fine on my computer, but apologies for that. One thing I think is really cool is that 64% of our staff are female, which I think for a tech company is probably unusual. I haven't actually done any comparisons, so I don't truly know that, but I believe that's true. Our CEO is a woman. Our COO is a woman. Our CXO, Chief Experience Officer, is a woman. We've got a lot of leaders at the executive level and the middle management level who are female, and I think that's actually fantastic. We divide up our remote employees into so-called member care teams who are responsible for a region. There are 5 individuals on a single member care team. There's the reporting person, so anybody who knows about meaningful use reporting, etc., needs to be on that team. The billing services, so OCHIN billing services, OBS. An account executive who's really the umbrella person responsible for the entire contract. Obviously, if it's an Epic customer, an Epic Care analyst, and then a Resolute analyst. And they work and live in the different states that you see here. This is our projection for the next few years. We're going to keep on growing. Now, I'm not a strategist. I'm not on the team that decides where we're going to go as a company. This is another stock slide. But it shows that our plan is to keep on growing. We're around here right now in the 400 area. And you can see that the ratio of professional services to technical is intended to grow as well. And this is in no small part due to our desire to really become a center of thought around how to take care of underprivileged populations. Right now we're providing a lot of really good technical services. And we're providing some really good support services, professional support services. But it's an area in which we can get better, hence my earlier reference to we don't run any clinics. We don't run any healthcare organizations. But maybe if we're going to get into this space, we kind of need to, so we know what it's like to actually walk the walk. I'll jump over to research now. We do a lot of research on the safety net, our data set on the underserved. I keep hearing one of the largest or is the largest in the country. I don't really know what it is. It's big. And I'll show you a slide that shows you the number of patient lives that are in that database. But since creating the research program, and many of you probably know Jen DeVoe, who's currently the chair of family medicine here at OHSU. She was our chief research officer until about a year ago. And so she's headlined a lot of this work. And in 2017, you can see the sort of numbers that we're really proud of in terms of the volume of research that we do. Now, there's a really good reason for that, right? If you do a lot of really good research, you're more likely to get grants. My salary is completely paid for by grants, which means I'm on like 7 research projects, which has been really interesting for me and also helps with paying the bills, obviously. These are our research priorities. Chronic pain and opioids, we'll talk a little bit more about that in a second. Diseases affecting the safety net, primarily chronic conditions. Health equity, health policy, informatics and research data warehouse, practice transformation, reproductive and family health, especially with our relationship with Planned Parenthood now that's been an important addition. And then social determinants of health, which everybody's talking about these days. We are engaged with Epic on an almost weekly basis in helping them design their social determinants of health tools, which are going to be receiving the primarily big rollout with the 2018 version, which I believe is going to be released in March or April. So I was mentioning this slide would come up. This talks about the size of our data set. So on Epic alone, we have 2 million unique patients. In our research database, we have 3.5. Our Curate data aggregation, so again, this is our aggregation engine, right, has a lot of patients as well. With the next-gen data, 1.8 million, and then altogether about 10 million. There's a little bit of overlap, but not a huge amount. You'll notice, if you're looking at the columns, that, let's see, where was it? Here we go. So with our Epic and research and the Curate data aggregation, about half of the patients that we have are at or below 100% of the federal poverty line. And you see that decreases with next-gen, and that's the Planned Parenthood edition, because the 5 practices that we host are all FQHC, so they actually have the same demographics as these other groups, in case you're looking for discrepancies in these columns. And we also offer a variety of other things. So I mentioned the professional services. So we provide quality improvement, process improvement consulting, revenue cycle management, network design, technical services, management services. If an FQHC says we need help with something, we probably have a service for you. And finally, in terms of what we offer, we provide a training institute. And this is not just for our customers, it's actually for our own staff as well. So when I first joined OCHIN, I had never bothered learning Reporting Workbench. And one of the first OLLI courses that was provided was how to use Reporting Workbench. So I took it. It was very helpful. I took a quiz and I learned. So this is something that's free to OCHIN staff. There is a cost for any members that we have that want to take an OLLI course. But we provide this. And actually, I'll talk about Dr. Chinsalapani in a second, who actually became an OLLI presenter twice while he was doing his rotation. and taught our members the basics and advanced skills of coding and documentation. Okay, so that's about OCHIN. So let me stop there for a second and see if there are any questions, if there are any conceptual queries you have about, what is OCHIN, what do we do, et cetera. Please.
I was wondering if you could talk a bit more about the...
You've got a mic coming up behind you.
Oh, thank you. Oh, yeah, there's a new system. Could you talk a little bit more about the kinds of research that you're doing? So I saw all the different areas that you're doing research in, but like what kind of
Sure.
study designs
Yeah.
and approaches you're using?
Be happy to. So I will, so first of all, I'm not a researcher. So when it gets to design, I start feeling a little bit uncomfortable. I'll tell you what I'm involved in directly. I'll give you 2 or 3 examples. So there is a group in Minnesota called Health Partners Institute, or HPI. They have created a clinical decision support tool around cardiovascular health, which is a fantastic tool that takes in a patient's data, crunches it through their proprietary algorithm, which is created by a combination of various evidence-based guidelines, but they put it all together. And based on those inputs, they then give you a set of recommendations to the provider, but also to the patient, saying, these are all things that are important, but your priority number 1 today is this. So obviously if the person's a smoker, that's always priority number 1. Take that aside. How do you know whether it's more important, meaning what reduces their risk the most if they lower their blood pressure or take a statin for their cholesterol, right? This algorithm tells you that. And so it presents it in front of the patient first while the patient's waiting for the provider, which is a great use of that time, right? Because they're always waiting. And it says, these are the things your doctors can talk to you about today. This is priority number 1. This is priority number 2. This is priority number 3. So by the time the doctor comes in, and he or she has their own sheet that says pretty much the same thing, but in more doctor language, it says, these are the things you should talk to your patient about. So they sit down, and they've already both had internal monologues about the same data and the same recommendations. And so we're engaged in working with HPI to make this tool a reality within our Epic for some 30 clinics, I think. There's 30 in the control group, and there's 30 in the intervention group, or 60 and 60, I can't remember. And the idea is, in the FQHC population, does this kind of tool lead to really good surrogate outcomes that would make us want to expand it across the entire collaborative? So that's one example. Another example that I'm working on is we're working with a researcher at Virginia Commonwealth University named Alex Christ. Alex is on the USPSTF, so he obviously comes with excellent background in terms of what he's trying to do. What he's trying to do is create an interactive, personal patient portal experience around preventive care. And what you do as a patient is you log into Epic's portal, which of course is MyChart, and you go to the My Preventive Care module. And My Preventive Care has already downloaded your information from your chart about what vaccinations you've had, what screenings you've had, or what you haven't. And it educates the patient in patient-friendly language about why it's important to do these things that you haven't already done. And then the next time you go see your doctor, maybe you should talk to them about this, right? The preliminary data, it's just preliminary, shows a doubling in the recommended screening and vaccination rates in the FQHC population, something that has not been shown with this technology before, to my knowledge. And that was presented in NAPCRAIG a couple weeks ago. So those are 2 examples. I'm trying to think about, I worry that I'm not going to give you a representative sample because I'm obviously involved specifically based on my skill set. I'd like to, if you're interested, I'd like to put you in touch with the actual researchers at OCHIN,
Yeah.
so you can get a better answer.
That's really helpful, though.
Okay.
Very interesting. Thank you.
You're welcome. Basically, it's health IT technology. I mean, health technology, essentially, research.
Focusing
Yeah.
on population health.
Those two projects certainly do. I don't want to make a generalized statement just yet. Yeah.
Thank you.
Of course. Thank you. Other questions? Vishnu.
Oh, and I should have mentioned, if you need CME for this course, contact Lynn, and she will hook you up with CME. I should have said that at the beginning. But Erik, can you go back one slide, please, to this one more. There you go. So this, to me, was really exciting when I saw it, because to me, trying to mine the EHR data is the obvious thing to do with the EHR now in 2017. But if we fundamentally believe that the purpose of delivery of healthcare and the use of technology like the EHR in healthcare is to improve the health of populations, then the gold standard that we should be held responsible to is how do we manage to improve the healthcare of the lowest strata of our society, the vulnerable, the disenfranchised folks, the people who are traditionally, utilizing the safety net. And so it really, to me, this graph suggests an extraordinary opportunity to bring up the level of the healthcare of the nation from the bottom up as opposed to how we traditionally do it, which is the top down. And so my question to you is that I know you guys are doing stuff with this data, and I'm sure that you will disseminate your findings, but the kind of tools and techniques that you use to mine this data, do you have some kind of a strategy at OCHIN or a long-term vision of how you're going to allow other organizations to do the same kind of innovative things with the data for safety net populations as you're doing in OCHIN?
Yeah, thank you, Vishnu. So we partner with other CDRNs around the country, and they have access, through data use agreements. We have access to their data, they have access to our data. We're always open to doing those kinds of partnerships so that there's a mutual, give and take to that. The other intriguing possibility is something that actually Jim Morrison came up with, which was when he was scoping out whether or not Acure's HL7 connections could all be upgraded to FHIR connections so that we could create a FHIR API and others could query those same data. But that's not something that's built out just yet. To answer your question, though, the partnerships that we do are something we want to continue so that data set is always available to others. I'll move on to our informatics team. So late 2016 when I joined, this was the informatics team. Now keep in mind, this is an organization that serves about 5,000 providers, 4,500 to 5,000 providers, 100 plus organizations, complicated build that has to be spread out across those 18 states. That's a lot of work for this team to do solely. And the strain was starting to show. Part of the reason that I was hired last year was because they were looking to really grow their informatics team to try to make it so that you didn't have just occasional individuals making really, really important decisions without discussing en masse. And so Scott Fields, who some of you may know, has been a longtime member of the family medicine department here at OHSU, and he's also our CMO currently. Karen Parr, who is a practicing nurse practitioner at OHSU Richmond, so using OCHIN's Epic, was full-time primary care clinical informaticist as well, and she actually was an analyst by training before she became an informaticist. So she was a nurse practitioner, got her analyst certification, and was working in the analyst space, and then moved back into the clinical informatics role. And then Shauna Zager, who was a practicing social worker, decided to become trained as an analyst, and then joined OCHIN, and has served in that capacity for behavioral health, mental health, addiction medicine. And both have done a terrific job, but they both also only have 24 hours in a day, work 5 days a week. Actually, both of them probably work 7 days a week, and there needed to be more capacity. So we grew the team. So this was a year later. The team has really expanded. You can see Sean is still there, and where's Karen? Karen's still there, and then Scott's still there, but we added all these other people. And these are their credentials and roles. So I'll just very quickly go through them. Anisha comes from 11 years of informatics experience in Atlanta, where she did mostly inpatient and pharmacy, but rose very quickly to become an operational manager and does that exceedingly well. So she and I are partners. We basically have a dotted line in the hierarchy at OCHIN where she essentially manages operations, pushes things through, makes things happen. And everybody reports to her instead of to me, which I'm very happy about. Julianne has 10 years of OB experience at Multnomah County. Oh.
No, it's probably just motion detection. There we go.
Oh. Oh, interesting. People on the phone, we had a technical glitch.
Fix the other one too. One sec.
Glad you were here.
Turning the projector on right now. Projector's coming on.
Well, what happens is that the power shuts, so the thing goes off and then comes right back on, so it gets screwed up because it doesn't know what it's supposed to be doing.
Thank you for helping to figure it out. Well, I'll take questions right now while we're waiting. Please.
I had a thought about the FQHCs and access to your services. How do they pay for it? How does that work? Because I would think this would be a wonderful type of resources for them to have, and I imagine there's many more FQHCs out there that might also like it.
Yeah. We cover less than 10% of the FQHC market in the country. I think I heard last year was like 5%. I haven't verified those numbers, but we have a tiny section of what's available. FQHCs eventually find a way. They have to. And they hear about us from mostly word of mouth, where they say, oh, you know, we thought we were too small to get Epic, so we want Epic, and this is the way to get it, right? We also get referrals actually from Epic directly. So Epic says, hey, we got this customer or this wannabe customer, but they're too small or whatever. Do you want to reach out to them? And then most recently, we've actually had some large healthcare systems say, you know, we could extend our instance out to them, but it's not business savvy for us to do so, but we want them on Epic so we can do better, more discrete HIE. Would you be willing to work with them so that we can communicate through Care Everywhere with them, but we don't actually want to host them ourselves? So it just kind of depends on what they're in the market for. I won't lie, our services are not cheap, right? So it may be that the price tag is actually still too high for them, that they still want to go and get their own next-gen instance or something that's a little bit less expensive. But I'm not really sure where the price cutoff is, because we have clinics where there's one provider, and we have clinics that have thousands of providers, you know, so maybe that's exaggerating, maybe hundreds. Molina Healthcare is our largest customer. I don't know how many providers they have, but they have the most out of all of our customers. So the range in size really spans the gamut. We do notice that the organizations that are smaller tend to engage with us less. So we have a number of work groups, a number of committees that we ask our members to come and join us and have conversations with us. The large and medium-sized ones always show up at the table. The small ones don't. And that's probably because they just don't have the staff to spare. If you've got one provider and they're always seeing patients, they're never going to come to a committee meeting, right? So not being involved in the business space, I'm not sure what the denominator is of people who could be our customers and how we increase the numerator of those. But yeah, I mean, it feels to me like we're providing a good service. Yeah. Does that answer your question? Okay. Oh, we're back. Awesome. Thank you. Thank you. Okay. So I'll keep going. So Julianne has about 10 years of OB experience at Multnomah County. She joined us as a trainer, and she joins us on our calls to help make determinations on OB questions that, oh, please.
She's one of our grids.
One of your grids?
Graduates.
Oh, graduates. Oh, okay. I don't think I knew that, actually.
So
She's,
Tom Durkin, so
yep.
Brian Laraway.
Yep. Yep. I knew about Brian and Tom, but I did not know about Julie. So I'll have to go bug her. She's very humble. And then Stacy Carney is a practicing internist who also uses OCHIN's Epic at Neighborhood Health Center and is now our lead for clinical decision support as of actually this week, which I'm exceedingly excited about. We'll talk a little bit more about that. Cherie Dunn handles our health maintenance. She's a nurse and a senior analyst. Scott, I've already talked about. Claire Fontaine is a workflow consultant, spent many years as a nurse practitioner, especially in STD clinics, so brings a lot of that experience with her. Christy Gray is a practice coach. She's an occupational therapist. We don't get a lot of questions about OT, but when we do, we know who to go to. Marshall Hammond is a senior application analyst, also a nurse practitioner, doesn't currently practice anymore, but has that clinical knowledge, obviously, and experience. Joe Nelson is a fantastic person, trained as a PA, really good at what she does in quality improvement, and is the kind of person who isn't going to say something to make you feel good. She's going to tell you the truth, and it's always helpful to have somebody around. I mentioned Karen already. Jeff Richter is one of our most important people. He is a PT by training, but has a wealth of experience in the software industry, actually, in product development, and serves as basically the manager of all things on our team. And then I mentioned Shauna already as well. There are non-clinicians working in the informatics space who nevertheless have a lot of really helpful experience for us. We already talked about Tom Durkin. Maureen comes with the next-gen package. When we purchased the company that hosts, Maureen came with all her certifications, see all the initials after her name indicating all her knowledge. And then Pam, who used to work in the dental industry, is now responsible for dental projects for Epic Wisdom, for example, or for our Dentrix installations. And then Lily Tran, who basically coordinates a lot of our activities. So the whole purpose of the previous two slides is to show you that informatics at OCHIN is really changing and growing almost by the month. And this slide is going to get bigger. There's going to be more people we're going to add. And we actually have a job opening that we just posted yesterday, actually, that will increase our next-gen capability from the clinical standpoint. I've had to learn next-gen and actually went up to practice in Seattle for 3 or 4 months, just like 1.5 days, 2 days a month, just so I could learn it from the user perspective, because we didn't have the clinical knowledge of next-gen or as a user at OCHIN when we acquired the company. And we felt that that was important. So thankfully, one of the clinics that we host was willing to let me go up and see patients. And my Washington license actually became useful. All right. So what do we do? So we provide clinical input and informatics input on anything and everything. And the volume of email that I was receiving was astronomical when our team was smaller and we didn't have defined roles. That's gotten a lot better. The pinging has reduced. And that's because we're creating more of a structure around how we do business. And I think that's an important point to mention, that in this very operational job, we've really had to try to be kinder to ourselves in how we help out the rest of the company. We are responsible for having the clinical conversations with our customers. Remember, our customers are healthcare organizations, something we don't do, right? And they are physicians, they're medical directors, they're also operational leaders and executive leaders, and those leaders can talk to my CEO and COO. But the medical customers, the MDs, the DOs, the NPs, the PAs, the nurses who have clinical questions, that's my job, that's my team's job to try to answer their questions and come to resolution on any issues that they bring up. We realized early on that we don't provide optimization training to clinics that don't have any other way of getting it. So they get an Epic installation, they see patients, but nobody's telling them how to do it better. Nobody's telling them how to become more efficient, right? And Epic does have some resources available on their user web that pops up that says, you know, you could do this, you could do that, but there's no systematic way of pushing content to our customers. Are we good on time? 15 minutes until the end, or 15 minutes until, okay, so I've got 5 minutes till Q&A, right? Okay, thank you. And so we've really been working on that. Obviously, our favorite thing is to sponsor the OHSU Informatics experience, which we'll talk about a little bit more. And then we sponsor the Physician Builder program that's out of Epic. I'm going to start speeding through a little bit just to give enough time. So when inputs come in, product enhancement from our IT team, research questions, member tickets on complaints or recommendations for improvements, regulatory requirements, again, state-specific regulatory requirements and federal regulatory requirements, any changes from Epic themselves, any requests from OCHIN leadership, any requests that our own team dreams up, funnels through to this group called the Change Advisory Board, on which we do have a seat. And typically this is a technical can we and should we from a design perspective. If that passes that, it comes to our team for clinical vetting. We then run it by the clinical analyst to make sure that it's buildable. We take it to our Clinical Operations Review Committee, which meets twice a month. This is where our members, our clinical members, sit down with us and discuss what we propose to them. Remember, their inputs are to go through here. So this is kind of a one-way conversation. We tell them what we recommend, and then they return survey data to us indicating whether or not they agree or disagree. Then it comes back to us. We massage it a little bit more, and then we send it to the analyst to build. In a nutshell, this is our process. We have an opportunity with our larger team to build product ownership into our team so that Erik is not responsible for all of it, and Karen's also not responsible for all of it, and Sean is also not responsible for all of it. We each have our niche, and this is new for us. And this is why you've got all these question marks. We're still working on this to determine what's the best use of our time from a personnel standpoint. As you can imagine, there's a lot of disagreement, right? Some people really want to hang on to this, and another person also wants to hang on to the same thing. How do we divvy it up in a way that feels fair? A few areas, I really wish I had more time to go through this, but clinical decision support is my #1 priority at OCHIN. It is not something we focused on in the past few years. Now that we have a clinical team that can do it, now that we have a physician lead for clinical decision support, this is going to become our #1 priority from the clinical informatics perspective. Provider efficiency is something that it kills me when someone does something inefficiently when they're seeing patients because they could use all that time seeing the patient and not clicking away. So it's something we've actually invested a lot of resources into. We're providing these resources for free to our members in order to make them better. I probably don't need to say too much about this. Everybody knows that this is a crisis. This is something that we're working actually directly with Epic on trying to make better within our system. Patient portals is actually a big priority of Epic's. They would like more patients to use patient portals, and they're coming to us and saying, what can you do to drive patient portal adoption in the safety net population? And you'll notice our adoption rate's only 18%. The national average is actually only 25%, which surprised me. But the large behemoths that really know what they're doing, 70, 80%. Now we have a range between 0 and 85%. We have a clinic that's in San Francisco that has just made it their way of communicating. And so it's an opt-out procedure. We're trying to drive more of our customers to that. There's a variety of issues that come about with FQHC markets in that patient portal usage may not actually make sense for a lot of patients. Take Multnomah County, for example. Their mid-county clinic, half their patients speak English or Spanish. The other half speak one of 70 other languages, but not English or Spanish. How do you drive patient portal adoption with that population, right? 1 in 2 patients isn't going to really use it for communication. And we're really pushing the Epic Physician Builder program. There's some research from class showing that organizations that have physician builders have happier physicians. Okay, that's correlational data. There's lots of confounders, I get it. But we're trying to make our organizations have more skin in the game, do some of the build themselves, and we've developed guardrails so that the physicians who we don't own, who we don't employ, are building in our dev environment so that they can make things that their organization benefit from. And even better, maybe that the collaborative benefits from. Okay. So Jim, who you all probably know and love, came and wrote an exceedingly good white paper on how to change our HL7 connections for our data aggregation engine all over the fire. He presented to our executive leadership team. It was the only time I've seen Jim nervous. He doesn't usually get nervous, and there he is in front of our CEO, who's always got, you know, that look. And he did a terrific job. And our former CIO started making strategic planning based on his findings. Oh yeah, CME question. We started hosting last year, 2016, not 1995. Okay. So Inho went and did something that nobody else could do at OCHIN, which was he started investigating really down to the minute detail of direct addresses, why some transitions of care measures were failing for some of the practices that really needed the money for meaningful use. And he wrote this report showing how to avoid the problem in the future, because there was a combination of bad documentation, bad training, bad maintenance of direct addresses. He figured it all out. Really amazing service. Ben's been to OCHIN twice. The first time, he took the Blue Cross Blue Shield Health Index and basically said, let's try the same with OCHIN data, and had some really interesting findings, which he then made into a poster, which some of you may have seen. I'm going really fast, I realize this, but that's because I know we're running out of time. Most recently, and I don't want to steal his thunder, so I'm not going to give you all his results because he hasn't published yet, but basically he looked at Epic's provider efficiency profile, which are these gigantic 40-megabyte Excel spreadsheets that show every click providers have done in the organization, and try to correlate it with clinical quality metric outcomes, which actually have been very interesting preliminary data. And the famous Dr. Chintalbani built an opioid smart set, which is actually forming the basis of our larger opioid build at OCHIN. And we actually have a number of organizations that have gotten the Ames grant funding that they're now using to help fund the build, and Ani started it. Also, he did some research on the rules around clinical documentation and coding in the outpatient space, and they presented 2 webinars along with myself and Karen Parr, one of our informaticists, to the membership so that the doctors can figure out what do they actually have to document, what can they remove from their bloated notes. And then, I love this picture. I took this yesterday. He's so relaxed. So Brady created a code mapping tool named Cardinal, which our Acura leadership has actually prioritized as a top priority for development because it makes code mapping easy for data validation. And currently he's working on also a grant-supported, novel, customizable CDS tool. Did I mention CDS is my top priority? That consolidates all point-of-care information and makes it an EHR-agnostic set of recommendations that we could potentially show to Epic customers and next-gen customers and any other customers who might want to do that in the future. He's creating a prototype, obviously not building the whole thing. OCHIN really loves the fellowship program. And all I do is I basically just say, all right, here's Dr. So-and-so, let's open some doors, let's see what he or she can do. And the rest sort of takes care of itself, really. In the last couple months, I've been extraordinarily busy, and poor Ani has had to suffer my absence at OCHIN as I'm traveling here and there. So I've started building my team around the program so that they can be supportive of the fellows when I'm not available to be there. Now, fellows are adult learners, so they don't usually need much. You know, as long as you open the doors for them, give them a way to contact you, give them a direction, or help work with them so they come up with their direction, they can just do their own thing. And I've been so impressed with the intelligence, the drive, the determination, direction that every fellow that's come through has shown. And I'm very excited about the program continuing. We also now have a permanent desk for fellows, something that Ani didn't benefit from, I don't think, when he was there. But Brady's the first one, so it is now the fellow desk, which is good. One thing that Vishnu and I have talked a little bit about, but we should talk about in more details, how do we integrate the clinical experience at our member clinics? Remember, we don't own them, but we can certainly have conversations with them about how do we bring this fellow in to really see what it's like to do informatics at the clinic level as opposed to at the OCHIN level. This is my last slide. And how much time do we have for questions right now, Lynn? 6 minutes. I apologize for bringing too much content and taking too long to present it, but questions for me? Mike, you get people on the phone.
So in terms of numbers, what's the relationship or the proportion of Epic and next-gen customers at this point?
Oh, there's 106 organizations on Epic and 5 organizations on next-gen that we host. The next-gen customers that are on Planned Parenthood, the Planned Parenthood customers that use next-gen use an instance that we don't host, but we support their templates. So it's mostly Epic. In fact, if you come and see our work groups, etc., they're almost always a little too Epic-centric, considering we're also a next-gen shop now, and we're trying to be cognizant of that and trying to be conscious of that, especially when we talk to the customers, right? Because if we're talking to them, we're starting to use Epic terms, they're not going to understand it. It's something we keep on having to pinch ourselves and say, all right, just remind yourself, keep it EHR agnostic, the language.
Eric, so I dealt with this a little bit when I was working on the opioid project, but I was hoping you could talk about it more with the group of when you're spread out across the country, and we talk about standardization versus customization, how do you make that decision, or how are those conversations had about we want to build something and we want to roll it out to all the providers? Well, how do we think about it so that a 10 provider clinic in Seattle versus a 30 provider clinic in Virginia, how do we make sure that our build is going to be successful regardless of where it's being implemented? How do you decide how much we standardize and how much we customize?
Yeah, great. A lot of emotional conversations, frankly. So we start out with the idea that if there's something that's regulatory, then we have to do it. And whether that's federal or state, that is sort of our bottom line, right? I mean, there's no choice really. If it's something like health maintenance, where we're doing vaccinations or preventive screenings, we've settled on USP-STF as being sort of our guiding principle. Now, anything outside of that, where somebody says, yeah, but for our patient population, we really need to do this. You know, for example, if you've got a mostly homeless population because you are Boston Center for the Homeless, then you're probably going to TB screen everybody, right? But we don't have a health maintenance topic that says TB screening for everybody. So for those customers who are outside of the norm, we build them custom build where it's possible. So our usual go-to is actually best practice advisories, because those have the most malleability when it comes to organization-specific needs, because other organizations won't see those. But every organization will see health maintenance. So it depends on the tool. If there's a tool that we can use to customize, we'll do it. If we can't, we need to decide by consensus. Not unanimity, so we take it to that CORC meeting, the Clinical Operations Review Committee, and we say, here's what this organization is suggesting. We think it's a good idea, bad idea. What do you think? And typically it's majority rules. If somebody's operational workflows are severely impacted by a decision that's made by majority, and they let us know afterwards, we just revisit it. You know, if it's not regulatory, we've always got time to discuss it, and we meet twice a month. And so we just keep on taking it back, make our informatics recommendation, but ultimately, the customers pay the bills. And so if there's something that they want, and we don't think it's going to break anything, or we don't think it's a terrible idea, then we'll generally do our best to implement it. So it's a lot of discussion, basically. But that is one of the bugaboos of this work, is trying to find good enough consensus.
So thank you so much for your kind words about the fellows.
Of course.
My question is, so I actually thought of this when the lights went out, so you have a bunch of customers. So what special challenges do you face during downtimes, and how do you kind of meet those challenges? Because it's hard enough trying to deal with it in an institution, but you have some control over the end user. In your case, they're scattered across the country and scattered across time zones.
Yeah. Do you mean scheduled downtimes or unexpected downtimes? Okay. Yeah. So our main method of messaging is email. And what we require by our contract is that there's always somebody at the organization paid for by the customer called a site specialist, at least one per organization. Larger ones have multiple site specialists. They're our main conduit of information. If there is a scheduled downtime, we always schedule it for a weekend. Remember, these are all ambulatory shops. We have no hospitals, okay? So there's a very small minority of our customers that work on the weekends, but most of them are Monday through Friday, which makes actually scheduling downtimes not that hard. So we'll usually say, we're going to schedule it for 3 to 5 a.m. on Sunday. You know, the chance that somebody's working at that hour, probably pretty slim. But we communicate it weeks in advance. And we try to fit it with we have a schedule where we say we won't do it except for, and I don't remember the detail, but it's like third Sunday of the month. If it's scheduled, it's going to be on this time. And we might use that space or we might not, depending on what's necessary. So we just communicate it really well. And there's really no choice. If there's a downtime, there's a downtime. We've got to do it for whatever. If it's unscheduled, the method of communication is still email, an urgent email to the site specialist. So the site specialist's job is to monitor that email for anything that's coming along. Now, if there's a downtime, they instantly know it, right? Everything shuts down, nothing works, and the site specialist immediately goes to their email. And we also have a web portal that shows the status of the various technologies that we have at OCHIN, whether it's a Cure, whether it's Epic, whether it's NextGen, that shows, you know, if it's a red line, obviously it's down, and the ETA next to it, as well as the explanation. And then when it gets updated, the web portal, when it turns to green, it says what was the problem, why did it happen, and this was the resolution. There's a downside to this method, which is that everything hinges on the quality of the site specialist. And if they don't do a good job of communicating with their clinicians, the clinicians might reach out directly to us and say, what happened? But they're supposed to reach out to their site specialist and say, what happened? And the site specialist is supposed to be the person who communicates that information. Our downtime has actually been very low compared to the Epic average. Like, we get an executive dashboard summary of our performance, and compared to the nation, our downtime is on the lower end of probability. Other questions? Well, if you have questions later on, My email address is right there. Feel free to email me anytime. If any of you want a tour of OCHIN, the physical building, I'm happy to give it anytime. And I have business cards with me if you want to walk away with one as well. So really appreciate everybody's attention and great questions, and I hope this was helpful. Thank you.